Immunohistochemistry and molecular genetic tools in diagnostic ocular histopathology from the Department of Pathology at the Wills Eye Hospital. I have no financial interests pertaining to this presentation. Immunohistochemistry is a valuable adjunct that greatly facilitates and improves the accuracy of diagnosis in ocular histopathology. At Wills, immunohistochemistry is used most often in the assessment and classification of lymphoid tumors and pigmented lesions of the conjunctiva. Immunohistochemical stains that typically are performed on lymphoid lesions include B-cell markers CD20, T-cell markers CD3 and CD5, follicular lymphoma markers CD10, and CD21, CD23, BCL2, and BCL1 or cyclin D1. Almost all lymphoid neoplasms of the conjunctiva and ocular adnexa are B-cell tumors that stain positively with CD20. A large percentage of ocular adnexal lymphoid lesions are extramarginal zone lymphomas of mucosa-associated lymphoid tissue, or MALT lymphomas. Most of the small lymphocytes in a MALT lymphoma stain positively for CD20 and are negative for CD10. A small number of T cells that show similar staining with CD3 and CD5 are present. Mantle cell lymphoma comprises about 2 to 7% of ocular adnexal lymphomas. Mantle cells has a poor prognosis and frequently is widely disseminated at presentation. The nuclei in this case are larger and mitotic figures are present. In mantle cell lymphoma, the tumor cells co-express B-cell marker CD20 and T-cell marker CD5, but don't co-express CD3. The tumor cells also express BCL1 or cyclin D1. In this follicular lymphoma, the cells comprising the large neoplastic follicles stained with CD20, follicular center marker CD10, and are also positive for anti-apoptotic protein BCL2. BCL2 is negative in normal germinal centers. Immunohistochemistry is commonly used to assess pigmented lesions of the conjunctiva, including nevi, melanomas, and acquired melanosis. Immunohistochemical stains used for conjunctival lesions include melanocytic markers Melan-A and SOX10, HMB45, and proliferation marker Ki67. SOX10 and Melan-A used with a red chromogen readily disclose the number and location of melanocytes within the epithelium and are also used to confirm the presence of invasive melanoma. HMB45 stains melanoma cells, and Ki67 highlights the number of cyclin cells, which is increased in melanoma and typically is low in nevi. This montage shows a conjunctival melanoma arising from a nevus. Both the nevus and melanoma are intensely immunoreactive for Melan-A, but only the melanoma at right stains with HMB45 and shows cellular cycling with Ki67. In our lab, immunohistochemistry is used infrequently in the diagnosis of intraocular tumors. Most intraocular tumors and melanomas are retinoblastomas, and the diagnosis usually is obvious and immunohistochemistry is unnecessary. Immuno is used in rare cases like uveal leiomyomas or schwannomas. In this leiomyoma, the smooth muscle nature of the tumor is identified by positive staining for smooth muscle actin. Immuno is also used to identify primary tumors that have spawned intraocular metastases, like this metastatic breast carcinoma, which is immunoreactive for breast marker BRST1. Immuno is used to assess a variety of primary and metastatic orbital and adnexal tumors. The diagnosis of orbital rhabdomyosarcoma is confirmed using immunohistochemical stains for muscle markers like myogenin or muscle-specific actin. Immuno is also used to assess well-differentiated sebaceous neoplasms for abnormalities in DNA mismatch repair proteins, which are found in the Muir-Torre syndrome. Other tests based on molecular genetics are becoming increasingly important in diagnosis. These include the presence of characteristic gene amplifications, like the MDM2 amplification found in atypical lipomatous tumors, and translocations. Detection may require special procedures like fluorescence in situ hybridization, or PCR. Diagnostic chromosomal translocations and resulting fusion genes and fusion proteins occur in specific cancers and can be used to diagnose them. Most alveolar rhabdomyosarcomas have specific gene translocations and result in fusion proteins that involve the FOXC01 and the PAX3 or PAX7 genes. These translocations serve to differentiate alveolar rhabdo, which has a poorer prognosis, from embryonal rhabdo. Not all cases of alveolar rhabdo have an alveolar appearance on routine histopathology. These translocations are important prognostic indicators. Patients with a PAX3 FOXC01 fusion often have a significantly poorer outcome than patients with the PAX7 fusion, with 4-year survival rates of 8% and 75% respectively. Some fusion proteins can be detected with immunohistochemistry. For example, nuclear staining with the STAT6 immunostain is used to diagnose solitary fibrous tumor. This stain detects a characteristic fusion protein between the MNAB2 and the STAT6 genes. Immunohistochemical stains for fusion proteins are also used to diagnose pleomorphic adenoma and adenoid cystic carcinoma. Some of the ocular and adnexal lesions that have characteristic fusion proteins are seen in this slide and the following slide. Important molecular markers for prognosis in uveal melanoma include non-random chromosomal abnormalities, such as monosomy 3, and gene expression profiling, which has identified several classes of uveal melanoma that differ markedly in their behavior and prognosis. Inactivating mutations in the BAP1 gene, which predispose to metastasis, are found in 84% of class 2 melanomas. An immunostain is available to detect this mutation. Finally, immunohistochemistry is also used to detect expression of programmed death ligands such as PDL1 and PDL2 in ocular tumors and determine if they may respond to therapy with immune checkpoint inhibitors. Thank you.